Hi there, dear listeners, and welcome back to part 9 of our Pharmacotherapy MCQs series. My name is Dr. Nath Arwa. I am a clinical pharmacist by profession, and I am the founder of Progressive Pharmacotherapy Consultants, the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. We seek to remain your premier source of crucial tips for the high-impact pharmacotherapy services that you offer on a daily basis. So, I urge you to sit back and spare me part of your precious time to share some tips with you. Welcome back. So in our first patient case, a patient has an echocardiogram indicating an ejection fraction EF of 35%. The dose-dense portion of the doxorubicin and cyclophosphamide chemotherapy regimen is planned in a few days' time. Which of the statements below is correct concerning this planned regimen? Is it A, a non-anthracycline-containing regimen should be used in this patient's therapy? Or is it B, our patient should proceed with chemotherapy as scheduled with no need to monitor her ejection fraction? Or is it C, she should proceed with chemotherapy as scheduled and her ejection fraction should be monitored at least once every 3 months? Or is it D, she shouldn't receive chemotherapy of any type until her ejection fraction improves? I'll give you 10 seconds to make the correct therapeutic choice for this lady. So in my opinion, the correct answer is A. A non-anthracycline containing regimen should be used in this dear lady's therapy, and I'll tell you why. Now, since anthracyclines are cardiotoxic and our patient's ejection fraction is already below the lower limit of the normal range prior to even initiating anthracycline-based chemotherapy, an anthracycline therapy should be avoided. Such patients with an ejection fraction of 45% or less are at an increased risk of heart failure, and they should not, I repeat, they should not receive anthracycline or any other cardiotoxic cancer chemotherapy. Now, cyclophosphamide methotrexate alongside 5-fluorouracil is an example of a non-anthracycline-based regimen that is used in patients with breast cancer, for example. Now, because of that explanation, answer A is correct. Now, answer B to me appears incorrect because of the explanation I've offered concerning cardiotoxicity. Answer C as well is incorrect. Out there are no guidelines recommending more frequent monitoring in the patients with an ejection fraction below the lower limit of the normal range. And answer D, in my opinion, is incorrect as well. There are many other chemotherapy agents that don't cause cardiotoxicity to the same extent like anthracycline-based regimens do. I cited cyclophosphamide methotrexate co-administered with 5-fluorouracil, for example, what we call the CMF regimen. It's an example of a regimen that you can use in breast cancer patients without causing cardiotoxicity. So let's move to the next question, which reads, Y.O.J. is a patient with active breast cancer who was transitioned to warfarin after 6 months of enoxaparin therapy. She comes to the clinic 7 days after beginning her 4th cycle of regimen, carboplatin and gemcitabine for her metastatic breast cancer. Her INR, when she reports to you now, is 4. Pretty high, but she reports no significant bruising or bleeding as she brushes and as she goes for a long call. Now, which of the following is the most likely cause of INR elevation? Is it initiation of Ondansetron for nausea management? Or is it B, a drug-drug interaction with her cancer chemotherapy? Or is it the initiation of lorazepam for nausea treatment? Or is it finally D, 3 days of nausea and vomiting post-chemotherapy? I'll give you 10 seconds to make the correct choice. So in my opinion, the correct answer is D. It has been caused by 3 days of nausea and vomiting after the last cycle of her chemotherapy. Now, if you strongly feel answer A is incorrect, Ondansetron wouldn't be expected to interact with warfarin in a clinically significant manner. It's not recorded in literature at all. Now, answer B to me also looks wrong. Gemcitabine has slight potential to elevate INR. However, given that she began her 4th cycle of chemotherapy 7 days, underlined 7, acute nausea and vomiting is the most likely cause of this elevation in INR. Now, answer C appears incorrect to me as well, because lorazepam wouldn't be expected to interact with warfarin in any clinically significant manner. Now, I strongly feel answer D is correct. Experiencing 3 days of chemotherapy-induced nausea and vomiting could influence a patient's INR in multiple ways. For example, her dietary intake of vitamin K, to be specific, may have been reduced by this serious nausea and vomiting, and that may have affected the levels of vitamin K related factors, leading to an elevation of the INR. Let's move to the next question, which reads, which of the agents listed below would provide relief for patients who develops peripheral neuropathy after receiving paclitaxel infusion during his cancer chemotherapy? Is it acetaminophen or paracetamol, 1 gram given QID orally, or is it 200 milligrams of celecoxib administered twice a day, or could it be gabapentin 300 milligrams taken orally thrice daily, or could it be duloxetine 60 milligrams taken every morning? I'll give you 10 seconds to choose which one would give the best relief. So in my opinion, duloxetine 60 milligrams taken after breakfast in the early part of the day would be the best option. Answer A appears incorrect to me because according to the American Society of Clinical Oncology guidelines, which I would recommend you read, duloxetine is preferred as first-line treatment for chemotherapy-induced peripheral neuropathy. Now, although analgesics such as acetaminophen, the NSAIDs, and the COX-2 inhibitors can be add-on therapy, they are often useful only in mild to moderate pain relief. They should be used with caution, especially in patients requiring chronic analgesic therapy such as this one. And this therefore makes answer B incorrect as well. Answer C2 is incorrect in my opinion. Gabapentin is an antineuropathic agent that has been used to treat this kind of pain. However, its efficacy data is mixed according to literature reports out there, and duloxetine is preferred first-line treatment for this kind of peripheral neuropathy. That is according to the guidelines that I've just quoted. So that leaves us with answer D as the best option in this particular patient's case. So let's move to the next question. It reads, what would be the most appropriate initial course of action after port removal if a patient who had come for the cycle of chemotherapy suffered an extravasation of doxorubicin, which was being infused by his oncology nurse at the oncology clinic through a peripheral line? Would your best choice be active surveillance without doing anything? Or would it be application of a warm compress to soothe the pain? Or would you administer dexrazoxane? Or would you finally settle for sodium thiosulfate administration? I'll give you 10 seconds to make the correct choice. So, in my opinion, C is the correct answer. Now, answer A is wrong. Active surveillance could be considered. However, anthracycline extravasations are often very, very, very severe, leading to permanent damage if we sit back and do nothing. Therefore, this would be the worst option to pick. Answer B is wrong as well in my opinion. Applying a warm compress is recommended for some types of extravasation after chemo, but cold packs should be used in the event of anthracycline extravasations, not warm ones. That makes answer B wrong. Answer C, in my opinion, is the correct one. Dexrazoxane is the best antidote for doxorubicin extravasation and should be administered within 5 hours of extravasation. There are data out there to support this particular agent, the use of this agent, dexrazoxane. Now, answer D is wrong in my opinion. Sodium thiosulfate is not used to treat anthracycline extravasations. It is, however, used for platinum and mechloroethamine extravasations, not for anthracycline extravasations. So let's move to the next question, which reads, DNN is a female patient with breast cancer who is receiving a chemotherapy regimen consisting of doxorubicin and cyclophosphamide. She called the oncology nurse today to report a fever, and she later on presented at the clinic with hypotension and tachycardia. And when her creatinine clearance was checked by your lab, they found it to be 45 ml per minute, and she is neutropenic, according to your oncologist. So, which of the antibiotics listed below would be the most appropriate choice for DNN today to sort out her problem? Would it be a dose of Cefepime, 2 grams, infused over 30 to 60 minutes, thrice daily, or would it be 2 grams of Cefepime, infused over an hour, twice a day, or would you settle for 750 milligrams of ciprofloxacin, infused twice daily, or would you go for that oral regimen and give 500 milligram tablets of ciprofloxacin thrice daily alongside coamoxiclav, or given orally thrice a day? I'll give you 10 seconds to choose the correct answer. So in my opinion, B is the correct answer. I would go for Cefepime, 2 grams. I'd infuse that every 12 hours. Now, answer A, in my opinion, is incorrect. Although Cefepime 2 grams IV thrice daily is the standard empiric antibiotic therapy for febrile neutropenia in oncology patients, it is inappropriate for this particular case because of her new onset renal dysfunction. If you remember well, the creatinine clearance was 45. Now, answer B to me is the correct answer because of the same reason. Her kidneys are taking a slight hit, and Cefepime is usually renally excreted, so I would do renal dose adjustment, but maintain the same choice. Answer C, in my opinion, is wrong. Ciprofloxacin should not be used as monotherapy in oncology patients, especially with neutropenia. It would fail you. It would not cover all the microbes that are culprits in this particular category of patients. And answer D is incorrect in my opinion. It is, however, an appropriate regimen that you'd use as empiric treatment of febrile neutropenia, but in cancer patients, just as outpatients. And because DNN is acutely symptomatic and requires an admission, I would opt for putting her on IV medication and not oral medication as such. So let's move to the next question, which reads, which of the antiemetics listed below should a patient receive prophylactically prior to the scheduled paclitaxel dose? Is it Ondansetron, 8 milligrams, administered orally 30 minutes prior to the infusion of the chemotherapy? Or would you opt for a combination of 8 milligrams of Ondansetron co-administered with dexamethasone, 12 milligrams orally, in both cases, 30 minutes prior to chemo infusion? Or Would you settle for 8 milligrams of ondansetron orally alongside fosaprepitant, 150 milligrams taken orally, both 30 minutes prior to the chemo infusion? Or is it true that no prophylactic antiemetic therapy is required prior to infusing paclitaxel? I'll give you 10 seconds to choose the correct answer. So in my opinion, A is the correct answer. I would settle for 8 milligrams of ondansetron taken orally 30 minutes prior to the infusion. We know that paclitaxel exhibits low emetogenicity. Now, authoritative guidelines recommend a 5-H2 antagonist such as ondansetron or dexamethasone as single prophylactic antiemetic therapy, not dual. So A becomes a correct answer. Answer B is incorrect because either ondansetron or dexamethasone would be acceptable as single agent antiemetic prophylaxis prior to paclitaxel or other low emetogenicity chemotherapy. Combination therapy as such isn't indicated. We use dual agents specifically for the moderately emetogenic regimens of chemotherapy. Now, answer C, according to me, is incorrect. Fosaprepitant should be used before highly, not low, highly emetogenic chemotherapy, and it isn't necessary before paclitaxel, which is has low emetogenicity as such. Answer D is incorrect as well. Antiemetic prophylaxis is recommended before infusion of paclitaxel because it's classified as low emetogenic. So we'll move to the next question, which reads, FTK called the oncology clinic to report breakthrough nausea and vomiting with 2 episodes of emesis. But she tells the oncology nurse at the desk she is not dehydrated. After probing, she says, you establish she's not dehydrated. After receiving a dose-dense doxorubicin alongside cyclophosphamates, the so-called AC regimen. And she received it yesterday, to be precise. She received antiemetic prophylaxis with an NK1 antagonist for fosaprepitant, 150 milligrams IV on day 1, which was yesterday. She also received ondansetron, 8 milligrams IV on the same day. She also injected 12 milligrams of dexamethasone, and she was meant to follow up that with 8 milligrams of ondansetron once a day on days 2 to 4, and olanzapine at a dose of 10 milligrams orally once a day on day 1, followed by 10 milligrams daily on days 2 to day 4. Now the question is, which of the following interventions should be made to manage this patient's breakthrough nausea and vomiting after this call? Should it be add aprepitant 80 milligrams orally once a day, or would you add palonosetron 0.25 milligrams IV start in the clinic when she returns today, or would you add prochlorperazine 10 milligrams taken every 6 hours, or would you increase her oral dexamethasone to 10 milligrams taken orally twice daily. I'll give you 10 seconds to choose the correct answer. So C would be the correct answer. Now answer A is wrong. Data are not available out there to support the use of an oral NK1 antagonist therapy, such as aprepitant taken orally to treat breakthrough nausea and vomiting in patients receiving chemotherapy. So I would not gamble, I would not risk. Answer B is wrong as well. Data does not support the administration of Ondansetron for treatment of breakthrough nausea and vomiting in oncology patients receiving their chemotherapy. Answer C is the correct option. Adding chlorperazine is appropriate because it provides an additional mechanism of action. It's anti-dopaminergic in activity, and that would help effectively combat nausea and vomiting. Its addition is supported by antiemetic guidelines used by many chemotherapy centers. Answer D, in my opinion, is incorrect. Our patient should maintain her recommended dexamethasone dose of 8 milligrams orally once a day. Let's move to the next question, which reads, FTK's nausea and vomiting from hydroxystrobin and cyclophosphamide was severe. She was admitted for dehydration and electrolyte depletion after doing medication reconciliation at the oncology unit. The clinical pharmacist there establishes she was taking oxycodone 5 milligrams orally when necessary to ease her pain, and she was using an average of 5 doses daily. Previously, her pain was well controlled, but she hasn't been taking her oxycodone for the past 36 hours due to vomiting. Now, the multidisciplinary clinical oncology team wants to change her pain regimen to IV morphine by PCA. So their question to you is, which of the following initial morphine PCA rates should be recommended for our patient? Would it be 0.5 milligrams per hour, or would she have to double that dose, or would she require 1.5 milligrams per hour, or in your opinion would it be 3 milligrams per hour? I'll give you 10 seconds to choose the correct answer. In my opinion, I would settle for 0.5 milligrams per hour. Answer A is correct. Now, prior to vomiting, she was using a total of 25 milligrams of oxycodone. If you do the quick math of 5 tablets times 5 milligram doses, converting this to oral morphine using the equianalgesic ratio of oxycodone, which is 20 milligrams of oxycodone corresponding to 30 milligrams of morphine, the total oral daily dose of morphine should be, or would be, 37.5 milligrams. This oral dose should then be converted to the IV formulation of morphine using the ratio of oral morphine of 30 milligrams being equivalent to the IV morphine at a dose of 10 milligrams, resulting in a daily IV morphine dose of 12.5 milligrams when you do the math. Now, the infusion rate of 0.5 milligrams per hour is determined by dividing this 12.5 milligrams per day by 24 hours in a single day. And I would like to emphasize that no dose reduction is made for cross tolerance due to the patient's poor pain control at this stage. Answer B to me is incorrect because of the way we have done the math. Answer C and D are incorrect as well. So let's move to the next question, which reads, CNM is an 84-year-old male patient who presents to your accident and emergency with his spouse, who informs you he has been slurring his words for the past 2.5 days and experiences right-sided weaknesses. Now he has a history of hypertension, which is well controlled by the current regimen he's on. He also has gout. He's currently on 81 milligrams of aspirin taken once a day, atenolol 50 milligrams taken once a day, hydralazine 50 milligrams taken thrice daily. Those are for his hypertension. And he also supplements with a tablet of multivites taken once a day. Now, on presenting, his BP is 157 systolic, 88 diastolic. He has a pulse rate of 88, and his respiratory rate is 15, and he has a temperature of 37 degrees centigrade. The multidisciplinary stroke team requests you, or requests rather, you to assess his eligibility for a TPA. So, which of the following statements below would be your assessment? Would you tell them this patient is eligible for TPA and should receive it right away? Or would you tell them he isn't eligible due to the high blood pressure? Or would you tell them he isn't eligible due to the fact that he's taking 81 milligrams of aspirin daily? Or would you tell them he is not eligible because his age is advanced? I'll give you 10 seconds to choose the correct option. So in my opinion, A is the correct answer. Now, Mr. CNM is a candidate for TPA despite multiple exclusion criteria in the guidelines from the AHA and the American Stroke Association. He presented to you fairly promptly within the 3-hour window that is quoted in the guidelines. If he had presented after 3 hours, he wouldn't have been eligible for the expanded treatment window of 4.5 hours since he is above 80 years of age and his pressure is below 185/110. Now, answer C, in my opinion, is not correct. Aspirin use is not a contraindication to TPA if you read any literature related to stroke. Answer B is wrong as well. His blood pressure is below 180/110. So let's move to the next question, which says you are the clinical pharmacist deployed to the geriatric ward in your hospital during a routine review of the medication regimen of an 88-year-old male patient. You pay close attention to the American Geriatric Society 2019 BS criteria for potentially inappropriate medication use use in geriatric patients, even as you do your medication clinical checks. Now, for which of these medications on his profile should you make a recommendation to switch to an agent with a better risk versus benefit ratio? Would it be doxazocin? Would it be insulin? Would it be teriparatide? Or would it be warfarin? I'll give you 10 seconds to choose the correct answer. So I would settle for A, doxazocin. Answer A is correct because doxazocin is included in the BS criteria because it causes orthostatic hypotension in these patients, and it has therefore an unfavorable risk-benefit profile when used, especially in the geriatric population such as this particular one. Answer B is incorrect. Insulin isn't included in the BS criteria despite evidence of increased risks of hospitalization for its use in the geriatrics. Here, the benefits of controlling the sugars outweigh risks of hypoglycemia. Answer C is incorrect as well. Teriparatide doesn't appear on the BS criteria at all because it doesn't have unfavorable risks versus benefit profile in this population. And answer D is incorrect. Warfarin isn't included in this BS criteria list despite evidence of increased risks of hospitalization from its use in the geriatrics. Here also the benefits of anticoagulation outweigh risks. So it doesn't belong to that list. I would not tamper with it. I would substitute the doxazocin, number A, or option A. Let's move to the next question, which reads, AGM is a 77-year-old man with the following medical history. He suffers from Parkinson's disease. He has osteoarthritis and is hypertensive. Currently, he's on trihexyphenidyl, Carbidopa, levodopa, and he takes residronate for his osteoarthritis. He manages his hypertension with the low dose with the Lisinopril, and he also takes low dose aspirin. While performing his chart review, you note that his profile has been consistently greater than 95 beats per minute. He's been constantly in the range of 92 to 116 beats per minute according to his records. So which of the listed drug treatment recommendations would be the most appropriate for our patient AGM now? Would it be a discontinuation of Lisinopril and the addition of Metoprolol succinate? Would you discontinue Carbidopa, levodopa and add ortigotine? Or would you discontinue trihexyphenidyl and add rasagiline? Or would you swap residronate with denosumab? I'll give you 10 seconds to choose the correct answer. So the correct answer here is I would swap trihexyphenidyl and add rasagiline in its position or in its place. To me, answer A is incorrect. Tachycardia isn't a common side effect of Lisinopril if you read literature out there. So discontinuing Lisinopril wouldn't alleviate the tachycardia that AGM is experiencing. Answer B is incorrect as well. Carbidopa, levodopa doesn't commonly cause tachycardia, so discontinuing it would not alleviate the tachycardia. Answer C is incorrect in my opinion, because trihexyphenidyl is an anticholinergic agent or has anticholinergic effects, and these anticholinergic effects are substantial and they commonly manifest as tachycardia. So this medication is unsuitable for a geriatric patient due to the anticholinergic burden. So discontinuing it and switching to a monoamine oxidase inhibitor such as rasadilin is the most appropriate choice for this particular patient. Now answer D is incorrect. Tachycardia is not a common side effect of residronate, so discontinuing it would not alleviate tachycardia at all in our patient AGM. Let's move to the next question, which reads, L.J.O is a 66-year-old man with the following medical history. He has osteoarthritis and is end-stage renal disease. Now, during the clinic appointment today, he claims, and in his own words, I'll quote verbatim, "My pain medication are running my life." He has lost autonomy and he feels frustrated. Now, his current meds are Hydromorphone, 4 milligrams, taken every 4 hours orally, and he wakes up in the middle of the night to take another dose. On probing about the efficacy of the drug, he says, in his own words, "It works well for my back pain, but it's difficult to keep up with so many doses." There's a pill burden issue here, and with his age, maybe he begins to forget a lot. So, which of the drugs listed below would be the most appropriate alternative to Hydromorphone for Mr. L.J.O? Would it be methadone, 5 milligrams taken orally twice a day? Would it be meperidine, extended release capsules taken at a dose of 300 milligrams twice a day? Or would you administer morphine extended release capsules at a dose of 45 milligrams twice daily? Or would you settle for oxycodone at a dose of 30 milligrams twice a day? I'll give you 10 seconds to choose. So I would settle for methadone, 5 milligrams taken orally twice daily. Answer A is correct. Methadone is the safest choice for use in patients like L.J.O with end-stage renal disease because its pharmacokinetics are not altered by renal failure at all. It doesn't have any nephrotoxic metabolites either. Now, answer B is incorrect. Meperidine is a nephrotoxic metabolites that are also renally excreted, just like meperidine itself. Its use in patients in this category with end-stage renal disease is associated with an increased risk of seizures. Now, that would complicate issues due to the accumulation of that metabolite that is toxic in nature. So I would not opt for that one. Morphine and its active metabolite, the 6-glucuronide, is not very highly recommended in patients with ESRD. So I would not opt for that one. And D is wrong in my opinion because the clearance of this particular drug, oxycodone, tends to be reduced, so accumulation may occur in such a patient with end-stage renal disease. So I would not opt for it either. So my highly esteemed viewers and listeners, that brings us to the end of of part 9 of our series, and I'm very grateful you made time to be here. If this video in any way helped you, I would like to urge you to remember to like it and to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and I sincerely thank you for viewing and for listening, and I look forward to interacting with you in subsequent videos. So thank you very much.